Hi, everyone. My name is Kristen Lake, and I am the co-founder of Vetmedology. And I'm here tonight with Sean Dent, who is he has a doctorate of nurse practitioner and is an acute care nurse practitioner in human medicine. And tonight we're going to be discussing case management strategies for the new critical care DVM in the ICU. And basically, the first topic in this informal conversation with us is about case management strategies for new ER and ICU DVMs that are focused on critical care. So, Sean, do you have any kind of pearls of wisdom about how to go ahead and manage cases in an intensive care unit?
Ironically, I was talking to a new ICU nurse yesterday at work, and one of the things that we sometimes do, whether subconscious or not, is that we have a lot of bias when we look at cases. For instance, I had a patient who was arriving from an outside facility,
Hmm.
and of course, I don't know how much is similar in veterinary medicine, but human medicine, we get report from the outside hospital, from the nursing
Hmm.
staff, as also from the providers on the condition of the patient, what they've done, why they were there, and then the patient's transported to another facility, and we were the receiving facility, and they had gotten report. We had come up with some things that we knew we were going to look at, knew we were going to do. We were
Hmm.
discussing whether we agreed or disagreed with some of their interventions. And at the end of the conversation, I said, one of the things that you have to pay attention to is that you're going to have biasness when you receive this patient because of what you already know. You haven't physically seen the patient, but you're already picturing what they're going to look like. You're picturing how they're going to behave. You're picturing what they're going to respond to. And you have to try and separate yourself from your biasness. You have to try and view this patient as if you know nothing about the patient. Because if you let your bias dictate your care, you're going to miss things. And the miss things that you miss may not be life altering, but they could change the path in which the patient takes. So it's
Right.
it's important to, you know, at least try and recognize that you're going to have some bias, and that you want to try and look at a patient. Every time you look at a patient, regardless of you're familiar with them or not, you want to try and look at them with a clean slate. It's a brand new day, it's a brand new hour, it's a brand new shift, whatever the case may be. And what do I need to learn, and what am I seeing? And the thing that we say, at least in human medicine, is trust but verify. Just because someone told you something about a case, you absolutely can trust their judgment and trust their description, but you want to
Mhm.
verify everything that's going on, because, as we all know, patients' conditions change minute by minute sometimes. So even though what they saw
Absolutely.
five minutes ago is not what you're going to see now. So be my
Yep.
best piece of advice.
Yeah, definitely, like rerunning labs, getting vitals, immediately, things like that. Like it's super important to, address those concerns immediately so that you know exactly what situation you're working with and how drastically this patient's, condition has changed or not. So, no, that's great advice. Do you have any other little pearls of wisdom for new critical
Um, I don't. I
DVMs?
guess. I guess being humble, making sure
Mhm.
that you're humble enough to realize that you're not supposed to know everything, and that you shouldn't. Um, I've been in human medicine for 20 years. I've been in the ICU almost the entire time I've been a nurse and as a nurse practitioner. And at the end of the day, I'm always going to learn something new, even from people that have little to no experience. There's always
Right.
something new to learn. So I guess that cockiness doesn't help your patient, because
I fully agree.
a lot of people think that just because you have so many years of experience, that you know everything, or that you have learned everything you need to learn. And I always try to remember that everybody can teach you something. Maybe it's something
Absolutely.
small, maybe it's something large, but you want to approach every case, every situation with a little bit of an open mind. Sure, there are a lot of things that you're going to be the expert on based on your experience and your knowledge, but you want to have an open mind, because just because you know it works this way, maybe the way that someone else is describing, maybe it's a better option, or maybe it's better for the patient. So
Absolutely.
even though time and time again, repetition and experience has told you that this is the way it should go, this is the way it should work, when someone comes, someone new or someone unfamiliar comes along to help you with that clinical case, you want to try and have at least an open mind that to at least explore the option of, okay, well, let's talk about what you're suggesting. Why would we want to do that? Why wouldn't we want to do that? So I think at the end of the day, you have to make sure you're focusing on the patient, because that's really hard sometimes, is that you want to constantly remind yourself it's not about you, it's not about them, it's about the patient.
Absolutely. I fully agree with that. I can't tell you how many new grad DVMs in the ER and ICU that I've worked with over the years, that, they come with a wealth of knowledge, but, not particularly in the specialty itself. And, they are immediately humbled on their very first shift when they're taught something by a technician or an assistant or something like that. And it's so super important to remain open and unbiased to receiving information from others, because everyone, like you said, absolutely has something to teach us. I totally agree with you. Any other little pearls of wisdom on this topic before we move on?
I mean, I could continue. I mean, it's just I probably have one too many. I'm trying to think of something that would also help. Um, I guess to parlay off of the last suggestion is that you always want to remember where you came from. Is that I work with a lot of different learners, different levels of expertise and skill and knowledge. In human medicine, I work from, techs, nurses, aides, all the way up to world renowned surgeons. And, regardless of what is going on, you always want to try and remember that you were once the new person. You were once that person that knows nothing. And
Exactly. Bottom of the totem pole.
as obvious as some answers are, obvious to you are not obvious to others. And you can be the smartest person in the room, but you don't have to be an a-hole. You don't have to be mean. You don't have to be demeaning. You can
Absolutely.
be human about it, and I think that separates the good from the bad, is that there's a lot of people I've been blessed to be around, and some of the smartest people are tough to be around, because they don't have good bedside manner, or they're not nice. Just be nice.
Yeah.
I mean,
The people skills and the soft skills are so important in both fields, honestly. And I really feel that, we struggle with that just as much in veterinary medicine as you do in human medicine. We see the same things. And no, that absolutely resonates. Thank you so much. Okay, so for the next topic, we're going to talk about traumatic brain injury and choosing the right treatments, the whether to utilize opioids in these patients, the Glasgow Coma Scale scoring, BUN and creatinine levels, monitoring their hydration status, electrolytes, and osmolality, and basically make a case for utilizing continuous ECG, serial BP monitoring, and running serial kidney value evaluations. So as far as it goes, when it comes to choosing the right treatments in the ICU for a traumatic brain injury patient, what would be, some pearls of wisdom that you would have for that?
his brain. So you have to think of what is the worst case scenario. So, and I'm going to speak about human medicine, because I know in vet medicine there are things that you guys may or may not do that we do, like,
Mhm.
emergent brain surgery and things like
Right.
that. I don't know how applicable that is to
It's
veterinary
it's a rarity.
medicine. Yeah. So you want to, least invasive to the most invasive, and it's always about salvage therapy. So the worst case scenario is you have someone who had a brain bleed of some sort, and that brain bleed is expanding, or that brain bleed is worsening to the point where it's causing compression on brain tissue. There's something called the Monroe-Kelly doctrine, and I don't know how similar that is in veterinary medicine, but there's three elements of the compartment of the skull or the brain that matters the most, because remember, your brain is encased in the skull, which is a fixed space, and that fixed space has three pieces to that. You have the brain tissue, you have the CSF, and you have blood. If any of those three elements are getting larger or expanding, the other two elements are going to suffer because there's nowhere for it to go. It's in a fixed space. So, um, in patients who have traumatic brain injury, you have the blood that will continue to, accumulate within the cranium, which will then eventually cause compression on brain tissue.
Mhm.
So, a lot of salvage therapy has to do with trying to pull out CSF or try to pull out fluid. You had talked about hypertonic saline. Hypertonic saline is an osmotic diuretic, so it is salt water. It's the highest concentration of salt water that you can imagine. And the goal of an osmotic diuretic is to pull as much fluid away from the brain and out of the cranium as possible, by way of osmosis, which
Mhm.
is, everybody remembers that, fluid follows salt. So, and that's the basic way to think about it, is that fluid follows salt. So if you instill pure salt water, it's going to suck out the fluid away from the brain, away from the CSF, at least giving you some time to figure out what to do about the injury itself.
Mhm.
Hypertonic saline doesn't fix the problem, it's just a temporizing measure. It allows you time to figure out what um, the the permanent therapy is to fix the problem. In most cases, that's surgery, you know, and surgery could be something as simple as just boring a hole through the skull to allow the blood, CSF fluid, allow that blood to escape to alleviate pressure on the brain tissue, or to completely remove pieces of the skull to once again allow that pressure to expand and allow the brain to freely move without being compressed within the cranium. So, everything that we do when it comes to traumatic brain injury is trying to minimize or to stop whatever
Mhm.
the offending thing is. So, it doesn't matter if it's a hemorrhagic bleed, if it's a traumatic bleed, if it's a subarachnoid hemorrhage, if it's a subdural hemorrhage, if it's an epidural bleed. All the bleeds do the same thing. They're causing compression on brain tissue. So our job is to try and figure out how to, um, m- minimize the amount of brain damage as possible, because brain damage doesn't, or brain tissue doesn't grow back. So once it's compressed, once it's starved of oxygen and starved of blood, it's gone. It cannot be salvaged. So the other aspect of traumatic brain injury when it comes to maintaining that space within the cranium is blood pressure. So, because blood pressure is indirectly affects the amount of blood in that's circulating through the cranium. So, blood pressure management is something that you do in sync with that hypertonic saline or surgery. Um, Blood pressure management has to do with minimizing pressure in the brain by keeping blood pressure below a certain threshold. Because once it goes above a certain threshold, it's going to cause worsening compression on the brain tissue. So we use agents
Hmm.
to try and reduce blood pressure. We sometimes actually will induce hypotension so that
Hmm.
it minimizes the pressure within the brain. So pressure in the brain is called intracranial pressure. So our job is to try and minimize or to control the intracranial pressure of the ICP. I could keep going. So maybe you give me a more directed
Yeah.
question.
So what about mannitol?
Mannitol is the same thing
Hmm.
as hypertonic saline. It's an osmotic
Right.
diuretic. In human medicine, um, I believe mannitol is cheaper than hypertonic. So a lot of facilities, a lot of places only carry mannitol. They don't carry hypertonic saline because average normal saline, which is the isotonic medication or isotonic fluid that we give a lot of patients, is 0.9% of
Hmm.
saline, which means if you do the math on how much of each electrolyte you have, the sodium percentage as a whole is only zero point 0.9, so it's less than 1%, but it's high enough that it can cause increases in sodium. Unlike
Good. Yep.
hypertonic saline, which is 23%. So that's a huge jump. It's like
Hmm.
2.5 times what the concentration of normal saline is. So mannitol is, I don't know the electrolyte makeup or how concentrated mannitol is versus hypertonic, but in my world, you can interchange the two. So in my world, mannitol is readily available in seconds. So
Hmm.
the nurses can go down to the what we call the AccuDose, which is where all the medication is stored. Nurses can just literally run down the hall to the AccuDose, pull out mannitol, draw up mannitol, and we give the patient mannitol like that. Whereas 23% saline, hypertonic saline, has to come up from pharmacy, and in some cases has to be manually mixed by a pharmacist. So I guess conveniency sometimes is the advantage you get out of mannitol.
Absolutely. Yeah. Um, what do you think that we need to be looking out for with the BUN and creatinine levels when utilizing mannitol?
So mannitol is once again hypertonic. So mannitol is going to increase your sodium level. BUN and creatinine are not looked at nearly as much as your sodium level and your osmolality. Kind of in my
Mhm.
world, those two are interchangeable.
Right.
The only time that I think that BUN and creatinine might matter, and I don't know if this is even applicable, is I guess it could be, is in someone who has chronic kidney disease. Chronic
Hmm.
kidney disease, um, the sodium level in hypertonic and mannitol is going to accumulate faster, so it's going to jump faster. Um,
Gotcha.
so when we give either one of those medications, we need to monitor someone's sodium level as well as their osmolality
Hmm.
to a certain threshold. And in human medicine, that value is, I believe, I want to say 280. I could be wrong.
I think it's 165 millimoles per
Yeah,
liter.
yeah. So once you get past that threshold, you're causing permanent damage to other organs, as well as you're causing such a high level concentration in the blood and in the system that you can't dial it back. So you end up causing permanent organ damage not only to your liver and your kidneys, but it actually causes an opposite effect of instead of helping brain tissue, it actually harms brain tissue because of
It
the.
sets off those idiogenic osmoles as well, and that whole cascade.
And then you have because then you're starting to disrupt the blood-brain barrier, and then all bets are off. So,
Yep. Okay. So in veterinary medicine, basically our patients are obviously usually much smaller than humans. So our concerns do lie a lot with the sodium levels, the BUN and the creatinine because of the fact that their levels will go ahead and jump sky high. And I mean sky high in no time whatsoever after utilizing hypertonic or mannitol, basically. So, going ahead and checking those levels in our field every 4 hours is absolutely a wise thing to do. What is your stance on utilizing opioids in TBI patients?
It all depends on the condition of the patient, I guess, because
Mm.
this is a it's tricky because opioids can mask neurological symptoms. So
Right.
in the world of human medicine, you have to be comfortable with a neurological exam before you give an opioid. So let's just say that, someone's GCS is somewhere in the 12 to 15 range because of whatever's going on. If you give an opioid and then that GCS drops to an 8 or a 10, did it drop because of the opioid or did it drop because their whatever their problem is getting worse? Um,
Exactly.
the- when it comes to traumatic brain injury patients, we don't utilize GCH as much as we use what's called the NIH scale, which is the stroke scale. And I know that obviously is not as applicable in veterinary medicine, but the NIH stroke scale to do an evaluation, you're trying to evaluate someone's higher brain function as to whether or not they have um, cognitive abilities, or are those cognitive abilities being suppressed or damaged by whatever brain injury is going on. So GCS matters probably in the beginning of the assessment for us in human medicine, but
Mhm.
it doesn't matter nearly as much as the NIH stroke scale matters once the patient is in the ICU, once the patient we've created a plan. Someone may or may not be intubated. Someone may or may not have an evolving bleed. Someone may or may not be on antihypertensive medications. So we don't withhold opioids because that would be torturous. We just have to be mindful of how much we give, and I guess the thing that we always say is start low and go slow.
Right,
Okay,
right.
give a smaller dose, do a frequent assessment and see if the assessment has changed in any way, and then evaluate whether or not they're still having pain or whatever assessment you use, because it's also very difficult to assess a patient's pain level when they're intubated and sedated. So we have other scales that we use when it comes to physical assessments. We use, an agitation scale. We use an awakeness scale, and that helps direct whether or not we should give a patient more opioid medication. So I
Gotcha.
don't know if that answers your question or
No,
not.
that absolutely does, because we're concerned about the same things, and our patients do not have a voice, So, when we are, monitoring, utilizing the Glasgow Coma scale, for any kind of progressive deficits and things like that, opioids definitely go ahead and will bite you in the ass real quick if, that patient, is basically, spiraling downwards. So, that's always a concern and a question, for, new DVMs, whether, this warrants opioids and whatnot. And they usually go ahead and do it. And they also do it at the, lower dose and, frequency as well, and until they're comfortable basically with the patient's status. But do you think that continuous ECG is necessary for these patients?
In human medicine, not always.
Mhm.
Um, there are certain injuries that, okay, well, all brain injury patients are at a higher risk of having a seizure. We once again utilize the stroke scale as well as frequent assessments to evaluate whether or not someone is having a seizure or is prone to a seizure. Of course, there are patients that have a history of a seizure, and then that just those are very specific patients. But um, currently, there's not enough EEG technicians or EEG machines to allow to want that or need that or to get that. So you have to hedge your bets on your high risk patients versus all the other patients. Um,
Gotcha.
we don't hook up ever. We don't traditionally hook up patients who have brain injuries to continuous EEG
Hmm.
because they're. I don't know what the percentage is, but if I had to make it 65 or greater than 65% of patients who have brain injury patients never have a seizure. You know, can you have subclinical seizures that, once again, there's no physical outward signs and they can have what we used to call absent seizures? Of course, you can. There's no way of knowing that. But in the ideal world, sure, we'd hook them all up to EEGs if we could. But we all live in the same world where we'll have to pay for the staffing and the machines and the technology, because there are facilities in human medicine that don't have those capabilities in any way, shape, or form. They don't
Right.
have the EEG machines, the technicians, or the people who will, or the neurologist who can read the EEGs. So you have to rely on your assessment skills on whether or not a patient has a seizure, and if they have a seizure, giving anti-epileptic medications and then evaluating responses. So it's a tough situation when it comes to continuous EEG. I
Gotcha.
don't I don't very rarely are all of my brain injury patients on continuous EEG, especially you witness a seizure, you hook them up to the EEG and you catch the seizure. Now you know where the seizure is, what kind of seizure you're dealing with. Many times we'll do what we just call a spot EEG, and in nine times out of 10, spot EEG tells you enough until you witness other seizure activity. The key difference is that in human medicine, a lot of my patients who are brain injury patients, we empirically start them on anti-seizure medication, so anti-epileptic medication. They're put on it empirically during the first 7 days of their 7 to 10 days of their brain injury, just kind of like,
Prophylactically.
yeah, so like kind of like when a patient comes in with, some sort of shock state,
Hmm.
you're going to empirically start them on antibiotics because every patient has an infection until otherwise proven. And it's kind of the same thing with brain injury patients. Every patient has a seizure until otherwise proven. And so a lot of, and these are just neurosurgical patients, a lot of neurosurgical patients will automatically be put on an anti-epileptic medication. So,
Right. Okay. What about continuous ECG or EKG?
well, all of my ICU patients are on continuous EKG.
Right.
So I mean, that's the mere definition of being in the ICU. Everybody's on a monitor.
Right.
There, if you're in the ICU, you're on continuous monitor. Just
Hmm.
that's that's why you go to the ICU.
Right.
So
Yeah, in veterinary medicine, basically, we rarely have access to EEGs unless a neurologist is basically available to go ahead and read it. But that it's still not something that is really typically run or anything like that. It's a rarity, if anything, and basically utilizing continuous ECG in these patients. It may, you know, help to quell the tension basically that you may feel when it comes to a particular patient status. But we really don't see much benefit from continuous ECG monitoring unless we've got electrolyte abnormalities like a high sodium level that is in turn creating arrhythmias that we need to monitor.
definitely a difference in human medicine. Yeah, you're on a monitor until you're transferred or discharged out of the ICU.
Absolutely, 100%. All right, so let's move on to mechanical ventilation. What would you say are some key indications for mechanical ventilation for veterinary medicine, as well as management of their settings?
Um, in I guess maybe I need a little bit more insight on you, which patients in veterinary medicine are put on ventilators, because I'll tell you from human medicine is that patients get put on a ventilator because of um, hypoxia that cannot be corrected, hypercapnia that cannot be corrected, um, or what we call protecting their airway, as in someone is at risk of vomiting and aspirating, or there's a GI bleed that you want to make sure and keep anything other than air out of their lungs. So we put them on a ventilator because their mental status is in question. So, for instance, the best scenario I can give is that someone comes in intoxicated. Someone who comes in severely intoxicated is unable to protect their airway because they're
Right.
so sedate that we have to put them on the ventilator until the alcohol wears off. And then last but not least is patients who have some sort of process going on that they have what's called an increased work of breathing. So they're what I describe as they're running a marathon. So they're breathing 30, 40, 50 times a minute, and they're guppy breathing. So if you imagine what it's like to just walk down the street versus if you all out sprinted for a mile, would you be able to make them? Most of us wouldn't be able to make the mile in an all out sprint. I
Right.
wouldn't be able to make the mile in an all out sprint. And that's literally what's going on with a patient. So some things that I think about are someone who has a PE, someone who's having a heart attack, someone who's having some sort of chronic respiratory problem that they're unable to compensate. So increased work of breathing could be someone who has pneumonia, or
Mhm.
someone who has um, those are the big main ones. But there's actually some brain injury patients, depending on what kind of injury they have, because their brain's unable to tell their body how to breathe properly. That they'll have increased work of breathing, and if you wanted to put it into definition, it's literally increased minute ventilation is what it is. So,
Gotcha. Yeah, in veterinary medicine, we utilize mechanical ventilators for hypoxia that's refractory to other conventional measures, basically, as well as let me see here. Uh, and just basically ventilatory and respiratory failure, ARDS cases, things like that. So, things where the diaphragm's not working, infectious diseases, things like that, like rabies. Unfortunately, I know of a colleague of mine that rabies was the top differential in his list, and unfortunately, the owner wanted to continue with treatment no matter what. And, he had to vent the cat because the diaphragm was paralyzed at that point. And she could no longer breathe on her own, and ended up basically aerosolizing rabies throughout an entire veterinary hospital and caused the entire staff to have to get vaccinated. So,
yeah, I mean, from human medicine perspective, that's also someone who can't use their diaphragm, so someone who has spinal cord injury, whether they sever um, the the spine at like C3, C4, or if they sever the spine C4, 5, and 6, um, can affect their respiratory center of their brain or the diaphragm. And then someone who has something like very specific neurological diseases like Guillain-Barré and things like that they'll be intubated. And unfortunately, in most cases, they're on a ventilator the rest of their life, so they end up getting a tracheostomy and things like that. But mechanical ventilation is one of those things that the way that we have always been taught, the way that I look at it is ventilators don't fix lungs. Ventilators are just a temporizing measure so that the body can respond or fight a fix whatever it is that's causing the problem. If it's a pneumonia, you're on the ventilator until your body amounts a response to get better. If it's someone who gets intubated because they have hypercapnic respiratory failure, what is it that caused that? You fix the cause, they no longer need the ventilator. You
Yep.
know, it's always mechanical ventilation is you don't you don't intubate someone unless you absolutely need to, and then you don't take them off the ventilator until you have fixed the reason why they got on the ventilator in the first place. Fix
Absolutely.
the
The impetus.
Yeah, so it's, someone who got intubated because they had a really bad pneumonia like COVID, um, in, you know, a lot of people don't realize that we didn't intubate people because they had COVID because it was going to fix COVID. We basically intubated them just to help them survive the the illness. So ventilators never fix lungs. It's just a supportive measure in order to fix whatever is going on, whether it's no matter what the case, whether it's
Absolutely.
something as simple as you look at it like someone who gets intubated for a surgical procedure.
Hmm.
You got intubated for the surgical procedure was over, you get extubated. It's and that's while that's a very simplistic description, that's exactly how it works. Is that
Hmm.
most people most non-medical people think that ventilators are going to fix whatever's going on, and ventilators don't fix lungs. So
And that is always communicated in veterinary medicine as well, that this is supportive only, and and it's not curative whatsoever, and it's not going to guarantee anything. So we try to fully inform owners, basically, what their decision may lead to, and they may have a bill at the end of the day, and they may not have a pet at the end of the day. So we try to be as upfront as possible, and are very slow to move to mechanical ventilation, because the outcomes for those patients usually are extremely poor in our field, because the time frames that are required for the healing that needs to take place to occur is very costly, and it's such a burden these days, and it's just not possible. So
yeah.
what do you think about the management of settings?
Um, every s- in the beginning when you're learning how to manage a ventilator, everybody gets put on the same, and we joke about it, on the same crockpot settings. Everybody gets put on the same settings because that's what everyone's familiar with. But as time goes on, you have to customize the vent settings based on the patient's needs and the patient how the patient responds. Um,
Absolutely.
it you know if it's just a straight up you're getting intubated because of hypoxia and you're fixing the hypoxia, then the settings quite honestly don't matter too much. You could pick pressure control ventilation, you could pick volume control ventilation, you could do a variation of those settings. The oxygenation portion, what matters for that is how much oxygen you're giving them and whether or not they require a lot of PEEP. Most settings are dictated by the problem in which caused them to get intubated in the first place. Um, the way that we approach it is the ventilator, the patient's lungs will tell us what ventilator settings to pick.
Hmm.
Have a certain, you have everyone has certain parameters that we all look at. You look at tidal volume, you look at respiratory rate, you look at PEEP, and you look at FiO2.
Hmm.
Everything beyond that is just a little bit specialized based on the patient's needs. I've been doing this for about 20 years, and there are certain settings that used to be very popular and used a lot when I first started, and now really don't have a lot of application. Assist control is the most common because it gives us the most control. We choose the volume, we choose the rate, we choose the FiO2, and we choose the PEEP. Regardless of what the patient does, they're going to do what we've given them.
Right.
Every time a patient breathes, they're going to get the set rate and the set volume. Every time a patient takes a breath, set rate and set volume. They can breathe above the set rate, but they're still going to get the volume that we have set. So while it's the most reliable, most predictable, and has the most control, it is the most uncomfortable for an awake patient. That patient, because we don't breathe like that normally. Now, I can imagine that it's somewhat applicable to vet med, is that nobody breathes the same breath every time. Sometimes we take a deep breath. Sometimes we take a shallow breath. Sometimes we take a longer breath. Sometimes we take a shortened breath. Sometimes we do what's called a sigh. We just, that's not a normal breath. That's a sigh. Those are variable. Assist control settings are none of that. So if I'm awake on a ventilator and you're telling me to breathe 500, 500, 500, 500. Now I'm just giving a random number, but in vet med it could be 200, 200, 200, 200, 200,
Yep.
18 times a minute, 200. And if I'm awake and aware of that, I'm going to fight the ventilator.
Right.
So most assist control settings require some level of sedation because it's uncomfortable.
Absolutely. Yeah, we
Assist
absolutely
control,
utilize sedation as well.
correct. And assist control is the very nature. We're assisting the control. We can use either a set volume or a set pressure, and it serves the same purpose. We're not going to get lost in the weeds on that one. You can either choose it as a volume or choose it as a pressure based on your goal. And in the world of human medicine, I'm imagining it's similar in vet medicine. It's based on a patient's size, because even though I'm a 51-year-old adult that is 5 foot whatever, if I gain 300 pounds overnight, exaggeration, but if I gained 300 pounds overnight, did my lungs get any bigger? Did my lungs get any smaller? They did not. So you base your ventilator settings on a patient's height. So that goal, whatever that height, tells you what the lung capacity should be. And there's ranges. We use 6 to 8 mLs per kilo in the adult world. I'm imagining that it's different in vet med, but it's the same concept, same principle, is that you have a certain range that you use, and you can achieve that range either by setting the volume or setting the pressure. So that's assist control. And that gives you the most control. That's the most common setting everyone uses, because when a patient comes in with either hypoxia or hypercapnia, my job to fix that. The only way for me to fix that is to take control of the patient's breathing. And then once I've fixed whatever that problem is, now I need to pick another option. There's a setting called SIMV that, at least in the adult world, we don't use because it kind of doesn't serve a purpose. SIMV is literally the same as assist control, except when the patient takes a breath, they get whatever they choose. So we still choose the volume, we still choose the rate, the FiO2 and the PEEP. But if the patient wants to breathe above the set rate, they get whatever they want. So instead of getting the 500, 500 or the 200, 200, 200, if they want to take a really big breath, they can. If they want to take a really shallow breath, they can. So it allows a little bit of comfort. It doesn't serve much of a purpose, because in most cases, you're going to have a patient who is at some level sedated. Because SIMV, while it may give you a little bit more comfort, you're still giving them that set rate and that set volume. So it doesn't give the patient a whole lot of comfort. So in the world of adult medicine, I don't remember the last time I used it. I really don't. I've used it in one case where I had a severe COPD, and that has absolutely nothing to do with what we're talking about, but it's not used, quite honestly. I don't know if vet med uses it for other
Not
reasons,
often at
but
all.
yeah, SMV has fallen to the wayside because there's no advantages to it anymore. The only other setting that really matters is what we call pressure support ventilation, and that's the weaning setting. So your patient has gotten better and you've decided it's time to come off the ventilator. The only way you're going to know someone is able to come off the ventilator is by assessing their breathing capability and their capacity. And it's kind of funny because you're going to measure it by the same measures you use to intubate them. In most cases, whether you're intubating them for hypoxia or hypercapnia, the work of breathing is basically depth of breathing, rate of breathing. And that's literally the two things that you're going to measure in order to get somebody off of the ventilator, is that they have to live somewhere within these two extreme measures for someone to be extubated. Pressure support ventilation is represented by a fraction.
Mm-hmm.
Top number is the number or the amount of pressure that they're getting on inspiration. And the bottom number is the amount of pressure that is present during expiration, sometimes called PEEP. And PEEP is positive end expiratory pressure. And that's basically how much pressure
Well,
is needed to keep the alveoli open at the very end of expiration. So that moment between exhalation and inspiration, there's that small millisecond. That millisecond is when a lot of lung collapse happens because the patient's
absolutely.
lung, the patient's breathing hasn't supported it yet. So we give them just a little bit. Now in human medicine, PEEP for normal people like us who are not on a
Mhm.
ventilator, PEEP is maintained by your epiglottis. So your epiglottis flaps up and down, and it maintains this certain amount of pressure, and it's a very small amount. Some studies say it's 1, some studies say it's 5. Everyone just agrees on that 5 is average, so everybody picks 5.
Gotcha.
Pressure support ventilation, the fraction has to be as low as possible before you can get somebody off the ventilator, and the reason for that is a fraction of 20/5 versus a fraction of 5/5 means that the patient who is 20/5 requires me to support them with 20 millimeters of pressure for every inspiration that they make. Whereas if I'm on 5/5, they only require 5, which means that their respiratory mechanics are stronger.
Mm-hmm.
You want your patient to be as strong as possible before you extubate them because it sounds crazy, but the longer that you're on the ventilator, your body can actually forget how to breathe. And the muscles that you use to help expand your lungs, the in between your rib cages, those muscles get
The
weak
muscles.
really fast. Like within hours to days, those muscles will weaken and require you to exercise them. If you
Right.
can imagine that when you're breathing normally, you're breathing what's called negative inspiratory pressure. So you're taking a breath in, you're sucking air in. And the only way that you suck air in from the outside into your lungs is by dropping your diaphragm and contracting the intercostal muscles within your ribs, as opposed to being on the ventilator, which is called positive pressure ventilation.
Mm-hmm.
Basically, your intercostal muscles and your diaphragm are no longer working. They're just kind of laying there, and I'm blowing air into your lungs through a tube. That's why being on the ventilator weaken your respiratory mechanics. So,
Right.
sys control, SIMV, pressure support ventilation. The last thing to talk about is just FiO2 and PEEP. FiO2 is just the fraction of inspired oxygen,
Right.
and you can give upwards of 100%. The amount of oxygen you and I breathe in just the ambient air is somewhere
21%.
around 21%. You
Yep.
know, it's a little different,
Mm-hmm.
depending on your altitude level, but randomly it's about 21%.
Yep.
So being on a ventilator, you can give upwards of 100%. So you're giving pure oxygen. There's there's a concept called oxygen toxicity, although nobody knows how to predict it. Nobody knows how much oxygen for how long you give them before you develop oxygen toxicity, and it has to do with the accumulation of free radicals. And it can damage tissue to the point that causes irreversible damage. But there's no way of knowing how that happens. So most of us just say you only use 100% oxygen when you need to. You use the least amount of oxygen that gives you the most benefit. So if you keep in mind that ambient air is 21% oxygen, you want to try and get down to that as best you can. Most patients are perfectly fine on 35%, 40%. You have patients who have chronic lung disease that they'll need a little bit higher. Um, but you don't want to leave someone on 100% oxygen, 100% FiO2 for any longer than you have to. In in the adult world, when you have patients who have severe hypoxic respiratory failure, unfortunately, I have patients who have been on them for days on days on days. And to this day, I can't tell you whether or not they had oxygen toxicity because it was a matter of life or death. So I can't speak to that.
Right.
PEEP is, as we said, positive end expiratory pressure, the amount of pressure that it is needed to keep the alveoli open in between expiration and inspiration. You can give as much PEEP as you want. There's unfortunately a side effect to PEEP. So your rib cage is a fixed space, just like your cranium with your brain and the tissues inside of it is a fixed space. Your rib cage is a fixed space with all of your organs in your chest cavity, including your lungs, your heart, your major vascular organs. And PEEP can increase what's called intrathoracic pressure. So if you give someone enough PEEP, you can actually compress vital organs and you can actually compress your lungs. And if you give enough PEEP, you can actually damage your lungs. So we have, and I'm imagining that there's something, as comparable in vet med, that you have to look at two safety measures when adjusting ventilator settings. And you look at your peak and plateau pressures. Peak is your has to do with how do I want to describe this? The compliance and resistance of lungs. So how well a lung expands and comes back together, as well as how much a lung can expand, kind of like a balloon. You have a balloon that can stretch and can go back to its original shape. Stretch even farther, go back to its original shape. Diseased lungs can only stretch so far, and diseased lungs, if you stretch them too far, won't go back to their original shape.
Right.
So PEEP and tidal volume can affect the distensibility of your lungs. So there are limits to the amount of PEEP you can give.
Absolutely.
Depending
Those
on
were
what's going on. Sorry, go ahead.
no, go ahead.
Depending on what's going on with the patient,
Mhm.
a lot of an average high level of PEEP is anywhere from 12 to 20.
Mhm.
And the higher you get, the more risk you can have of lung damage as well as what we call barotrauma. So you can basically
Mhm.
cause a pneumothorax if you give too much PEEP, if you give too much tidal volume. So that's why
Absolutely.
those ranges matter when it comes to tidal volume, and those
Yep.
ranges matter in PEEP because you can cause barotrauma and you can
Yep.
cause irreversible lung damage.
Yep. That's at 20 millimeters of mercury for us.
Yeah.
Yeah, those were amazing reviews of basically the settings, and I mean, I'm so appreciative that you went through all of that because a lot of people literally just factor in minute ventilation, and like you said, it's weight based with the tidal volume and respiratory rate, and basically go from there, and really don't try to truly understand the range that's possible basically with the settings that can, provide more comfort for the patient. So thank you so much for going into all of that. Um, so next topic is the relationship between potassium and magnesium. Any pearls of wisdom on that?
Never treat either one of them in isolation.
Hmm.
And that is probably the best piece of advice I could ever give you, is that always remember that you have something called your sodium potassium channels, and your sodium potassium channels have to do with muscular contraction, has to do with the energy capacity of a cell, um,
Hmm.
and the ability of your body to maintain potassium is dictated by magnesium.
Right.
And a nephrologist once told me that your magnesium helps potassium stay sticky. And I may have said this on one of my social media channels, is that many of us will drive ourselves batty trying to replace potassium by whatever means possible. So you replace potassium whether oral or by IV, and no matter what you do, no matter how much you give all the potassium that you own, and the potassium doesn't get better, it doesn't budge. You want to look at your magnesium level.
Magnesium. Yeah.
You should always try to replace your magnesium before you replace your potassium. That way you don't waste potassium. Um,
Yeah.
Potassium levels are representative by two things: the amount of potassium, three things, sorry, the amount of potassium going in, the amount of potassium absorbed, and the amount of potassium lost. And of those three things, the magnesium level helps prevent potassium loss.
Mhm.
And that's probably the simplest version without going into the pharmacokinetics, which can be brain numbing. um, is that we all know the significance and importance of potassium. We all know
Right.
that it is cardioprotective. It also can cause severe cardiac abnormalities. Magnesium as well causes those same things. So you always want to manage your potassium with your magnesium. I don't know if this is in vet med, but in the world of critical care medicine, we have protocols for
Mhm.
nursing. So that if you're a nurse working in the ICU,
Mhm.
you get a bunch of labs every morning, and instead of having to call the provider every morning, hey, your potassium's low, hey, the magnesium's low, how much you want to give, we have things that are called protocols. And it's
Right.
a nurse driven protocol. So they see a potassium level that's below whatever the range is for the protocol. It's within their capabilities, responsibilities, and license that they can replace that potassium without an order from a provider based on a protocol.
Yeah.
In the world of the ICU, we have potassium and magnesium protocols. So that's not by accident. We have that on purpose, is that potassium and magnesium should be treated in partnership at all times.
Absolutely. No, that's so smart to treat it in tandem because um, one of the issues that we run into in veterinary medicine is basically funding for lab work and diagnostics. So we're trying to go ahead and pinch pennies here when we need to be testing for magnesium with potassium, so we're not wasting all of this IV potassium basically, and going ahead and giving that magnesium first if there's deficits and whatnot. And that's it's super smart. And I just feel that it's it should be an intuitive thing for us, and I just feel like it's just not carried out well. So I really appreciate your
Mirrors
stance on that.
in human medicine, because
Mhm.
um, the basic metabolic panel doesn't include magnesium.
Right, ours doesn't either.
Yeah, so you have to order that separately. So
Right.
from a cost perspective, yeah, that absolutely would cost more, but it it doesn't make any sense from a pathophysiological perspective. So that
Absolutely.
I imagine
Yep.
how frustrating that can be. So
All right, so for the next topic, vasopressors and the importance of knowing and memorizing their actions.
The best way to memorize, I guess the best way to try and remember vasopressors is to understand the receptors that they work on.
Right,
That's literally the easiest, the best and easiest way to remember it.
right.
Alpha 1, alpha 2, beta 1, beta 2,
Hmm.
understanding those four receptors,
Hmm.
understanding what each one of those four receptors do, and then remembering which vasopressor acts on which receptor, because then you can correlate what the end action is. So, for instance, epinephrine is the heavy hitter. It stimulates all of the receptors, so it just turns everything on. It is the strongest vasopressor that you can have, so it's going to turn everything on. So it's going to cause peripheral vasoconstriction, central vasoconstriction. It's going to increase your heart rate, and it's going to increase the squeeze of your heart. It's going to do all of those things all at once. Now, if you have someone that's sick enough, that that's what you want.
Hmm.
But if you have someone who has a known cardiac abnormality, that they're prone to some sort of um, ins unstable cardiac arrhythmia, then you may not want to give epinephrine, because epinephrine is going to increase heart rate, it's going to increase the squeeze. Increasing the heart rate by stimulating um, alpha 2 beta 1 is actually detrimental to your patient. So you'll know ahead of time that my patient has this particular cardiac issue, or my patient's already horribly tachycardic. Maybe I have a better choice besides epinephrine. Fully is understanding that some vasopressors can cause refractory hypotension versus hypertension. So even
Hmm.
though you started a vasopressor because their blood pressure is low, you give enough of that medication, and it actually can cause worsening low blood pressure. So butamine,
Absolutely.
one of those things that does that. Dopamine to a degree, because butamine's a unique drug because it's not a vasopressor. It's more of an inotrope, which means it just increases the strength of your heart. It doesn't do a lot for your blood pressure, but it helps your blood pressure because it increases the strength of your heart.
The
Because remember,
contractility.
yeah, so your blood pressure is dictated by your cardiac output, which is stroke volume times heart rate. So if
Hmm.
you can increase your heart rate, you can increase your cardiac output, which increases your blood pressure. Um, that's why Levophed is the drug of choice in many cases, because Levophed does all the cool things that epinephrine does, but it doesn't have the bad side effects that epinephrine has.
Right.
You can use Levophed in someone who is horribly tachycardic. Now, while it still will stimulate the alphas and the betas, that it'll still cause a little bit of an elevated heart rate, but
Mhm.
it's usually because you've increased blood pressure, not because you've stimulated the receptors. So it really it really comes down to just understanding the receptors and understanding what med affects each receptor. So, for instance, neosynephrine, um, which is also a great medication because it only stimulates the peripheral vasoconstrictors, and it doesn't stimulate anything in the heart. So
Hmm.
it's great at blood pressure, and it doesn't affect the heart rate at all. So we use neosynephrine a lot in our brain injury patients, because brain injury patients can be very sensitive to high heart rates, because it can actually a high heart rate can actually cause increase in ICP, which we've talked about is bad. So
Hmm.
we'll use neosynephrine in our brain injury patients because it doesn't stimulate the receptor that increases heart rate, but it'll help us with our blood pressure. So someone who is having blood pressure problems who has a brain injury will use neosynephrine. And
Right. In
it's
veterinary medicine, we just use the generic name phenylephrine for it, and more
sorry.
progressive hospitals. Oh, it's totally fine. I just wanted to clarify that for anyone that was wondering what that was. But in more progressive hospitals these days, we are seeing a rise of the use of phenylephrine finally. So that's great for us.
I mean, I hate to say it, I'm imagining that the choice of vasopressor is dictated by finances. Unfortunately, I'm imagining. I'm blessed and lucky that I don't see that side of the business. Is that I work in a facility that I pretty much get any of the meds that I need in most
Right.
cases. So I guess
They're all actually
it,
pretty comparable in veterinary medicine, actually. So basically, the patient's conditions and, particular needs for, what, effects we need to go ahead and apply to that circulatory system basically dictates, what is prescribed for them.
yeah, and I guess the other aspect of vasopressors is to understand what are you treating. You know, in adult medicine, you have to understand which shock you're managing.
Mhm.
What is causing their low blood pressure? Is it
Right.
because of a volume status? Is it because they're bleeding? Is it because they're septic? Is it because of a brain injury? Is it because of a blood clot somewhere? Is it because of a neurological deficit? So you not only need to be able to understand what vasopressors do in regards to the receptors, but you should also know what are you treating. In
Absolutely.
most cases, and I guess that kind of dives into shock management, is that you want to make sure that you are trying to identify what shock you're treating. Every shock, there's four different types of shock, and of the four types of shock, all of them are initially treated the same way, which is fluids. Everybody
Mhm.
gets fluids to start with,
Right.
but too much fluids is a bad can cause all kinds of bad things. But in
Especially
the
in
immediate,
cardiogenic shock.
yeah, in the immediate time frame, during those first couple hours, you can give fluids, and you're usually safe. But you don't want to just keep giving fluids without a plan.
Right.
Um, to your point, that's why you need to understand which shock state you're in because, you know, let's take for instance cardiogenic shock. In cardiogenic shock, the squeeze of the heart is weakened in some way, whether it be from a direct injury, whether it be from, an MI, or it could be from a clot, or it could be from a crushing injury where it crushed the chest wall and it's physically compressing the heart. You want to make sure that you understand the difference between that kind of shock versus someone who has septic shock,
Right.
because giving someone fluids and septic shock, you're going to have a very different response. And the heart
Absolutely.
is, in most cases, working okay. It's working overtime, but it's working okay.
Yep.
So you just have to make sure that you're cognizant of whatever intervention you're giving. I always tell my students and learners, if you understand the why, the what's real easy.
Yeah.
Understand the why behind it. The what is just reveals itself. You understand why we give Levophed. What's real easy. You understand why we're giving fluids instead of pressors. The what's real easy. You understand why we're not going to give epinephrine and we're going to use neosynephrine. The what's real easy. So it's always important to, and if you don't know the why, you ask, why are we doing this? If you're unfamiliar with something, or if you're not comfortable with something, always ask the why, because
Absolutely.
the knowledge is your greatest weapon. So never be afraid to ask why. And you always, I'm kind of going off subject. You always want to ask the question why, but you don't want to ask it in a accusatory manner. You don't want to point a finger and say, like, why the heck are you doing that? More importantly, you should be asking, I'm not familiar with that. Why are we choosing that?
Always
Always
come
wanna-
from a place of good intentions.
yeah, you always want to come from a place of knowledge, not of superiority.
Right.
Know? Just because they're familiar with it, maybe you're not, or vice versa. So when somebody asks you why, don't get defensive. Maybe
Mhm.
they're trying to increase their knowledge. So it goes both ways, and I think that sometimes we forget that. Is that just
I
because
agree.
once again, unfamiliarity. Put yourself in their shoes. Why are they asking the question why? And the same thing for you. Why are you asking the question why? So, sorry, I got
I
off
mean,
topic.
we are, all very judgmental creatures at the end of the day, and we've got to grow past that. So that's, great point. Okay, so management of multiple CRIs, which we call Christmas trees in veterinary medicine, and the evaluation of physiological effects in the ICU. How would you, basically describe is the best way to manage the physiological effects of multiple CRIs for new grads?
Verify for me again, CRIs.
So constant rate infusions.
I'm still a little confused on what that means. Like
Okay, so
fluid?
basically just a metered dose of a drug over time. Drips, things like that in human medicine.
We talking about vasopressors, or
The
can you give me an
pressors, it
example?
could be, Lasix, it could be, opioid pain meds, things like that.
Oh, okay. I see.
Mhm.
Um, the most important thing to know is like easily what you have and what you need,
Mhm.
and then medication interactions
Right.
between all of them. Because, depending on how much access you have, how many access points you have, is going to determine what you're giving and where you're giving it. Like when we give two different vasopressors, we have to confirm that those two medications are compatible.
Cool.
Because if
Yep.
they're not compatible, that means that there was some sort of documented interaction that can cause the worst case scenario is crystallization.
Right.
You don't want to have two medications
Particulate.
that combine and gel and turn into a crystal form, and then you're infusing that into your patient, and then all bets are off. Um, it's I mean it don't overcomplicate things. It really comes down to understanding the mechanism of action of the medication, understanding what the expected response is of the
Mhm.
medication, and understanding or recognizing what the patient's response was to that medication. For instance, in someone who is getting Lasix, someone's getting a diuretic.
Mhm.
How much medication do you normally give? How much does the patient require? Based weight based in most cases for a vet med. In human med, it's just standardized dosing. So you can give anywhere from 20, 40, 60, 80.
Right.
It's I guess theoretically it is weight based. So um, if you gave whatever that dose was, what is the expected response? So for someone that I give Lasix, the expected response is that I should get an increase in urine output in the next 10 to 30 minutes. If I don't have increased urine output in the next 10 to 30 minutes, why? What happened? Is it the medication? Is it the dose? Is it the patient? You know, and the KISS principle, keep it simple. Keep
Mhm.
it simple. So start from the most basic to the most advanced causes.
Mhm.
Simplest being, did I give the medication correctly? Did I give it through the correct means? Did I verify the medication? You've done all those simple things. Okay. Did I give enough of the medication? Did I give the correct dose? Do I need to give more? Many patients have chronic organ dysfunction. So, is there anything going on with my patient that would have skewed the response? Am I giving something that is blocking the medication from doing its job? So, understanding the pharmacokinetics and the mechanism of action of all the medications that you're giving. I mean, if you're giving a medication and you don't know all those things about that medication, don't give it. Don't.
Exactly. Honestly,
Don't.
we have a veterinary pharmacology book called Plums that's most utilized in the veterinary field, that goes ahead and breaks, the pharmacokinetics and mechanism of action, everything down, basically dosing ranges, things like that. And if, you've got a patient that has that's on two CRIs basically of, of different drugs that have similar mechanisms of action, and you're wondering why we have such an increased response to the medications, maybe potentiation, things like that. Like the simplest answer is usually correct.
Yeah, I mean, so, like when we give cardiac medications, we need to be very cognizant of what the two do. And are they canceling each other out, or are they going to magnify the response? Or someone who has compromised kidney function and I give them the standard dose, but giving someone with a compromised kidney function a standard dose is like giving them 3 times the amount that you would give somebody normally. So it's, you know, pharmacokinetics speaks to what organ in the body is absorbing it, what organ in the body is getting rid of it. So once again, if you understand the why, the what's real easy. And
Mhm.
the why matters for just about anything you do in medicine. It really
Right.
does. And if you don't know the why, then you better answer that question. So it's just, and it's a revolving it's a revolving door. It never stops. You know, you're constantly assessing and reassessing, regardless of what you're doing. I'm going to do this. I expect this, and then I'm going to assess. Why did that happen? Why did it work? Why didn't it work? What do I got to do next? Intervention, response, assess. Did
Hmm.
that work? Did it not work? Why or why not? And it's just that's all you do. All Every hour, every minute, that's all you'll ever do in medicine, especially in critical care medicine. So, yeah, I don't I guess from my perspective, those are sometimes the things that I forget about is that just is ingrained in me is that you have to know the why. If you don't know the why, you're doing a disservice not only to you and your profession, but also to your patient.
Absolutely. 100%. Okay. So we've talked about, it cost prohibitive, issues in the veterinary medicine field. It, I know that amiodarone is, widely used in human medicine. It's something that is very just financially prohibitive for veterinary hospitals, unfortunately, to carry. But is there a case that you can make for, veterinary hospitals that may be on the fence about getting amiodarone?
Ironically, I just talked about this on my social media channels, if not last night,
Hmm.
the night before, is that why the question was asked, why is amiodarone the go-to medication in the ICU? And the answer is safety profile.
It,
Um, it it gives all the wanted effects without all of the unwanted side
Wanted, yeah.
effects. Um, we use amiodarone a lot in patients who have AFib with RVR. So they have atrial fibrillation, but they have atrial fibrillation so fast that it's causing cardiovascular compromise. AFib in itself is not dangerous. In fact, it's people live with it all the time. I'm
Mm-hmm.
imagining pets live with it all the time because it's not a problem until it's a problem. Um, atrial fib by itself is not dangerous as long as it's managed appropriately. But
Right.
AFib with RVR means that your atria are spinning so fast that your ventricles can't keep up. So your ventricles work overtime, and then there's this horrible mismatch. And the key detriment to AFib RVR is you lose what's called your atrial kick. Your atrial kick is responsible for almost 20% of your ejection fraction, which is the squeeze of your heart, the strength of your heart. The squeeze or the strength of your heart in the human medicine is it's supposed to be around 60. Now,
Mhm.
that's supposed to be. If you take away 20% of that, now you're down to 40. Now you have someone who is already having compromised cardiac output. So they're already sick from something, shock of some sort. So
Mhm.
now the squeeze of their heart is now already compromised, and then you're going to take away the atrial kick. So most times AFib RVR results in hypotension,
Mhm.
severe hypotension. So we have to try and fix that fast so that we can slow down the heart rate so that the heart can catch up and your blood pressure can normalize. Many many places outside of the ICU will use cardizem to treat AFib with RVR.
Mhm.
Cardizem is a rate controlling medication. Amiodarone is considered a rhythm controlling medication. Cardizem is a calcium channel blocker. It affects one aspect of the cardiac cycle, and it's supposed to slow down the conductivity, which then slows down the rate of your heart. Unwanted side effect of cardizem is that it will cause severe hypotension because of the mechanism of action. So you can give a patient cardizem, it'll fix their heart rate, but in most cases, it's going to cause unwanted hypotension. Amiodarone is a medication used to kick somebody out of AFib back into a normal sinus rhythm, but it also can slow down the rate without causing hypotension.
Right.
So I that would probably be the only argument I have when it comes to amiodarone is that it is a powerful medication to help slow down dangerous heart high heart rates, but it also can convert someone from an AFib into a normal sinus rhythm, and that leads into another rabbit hole of a conversation of acute versus chronic atrial
Right.
fibrillation, whether or not they have, clot burden and things like that. And I don't know how applicable that is to veterinary medicine because, as you had mentioned, you don't traditionally have all your patients on monitors, so it's hard
Mhm.
to it's hard to sell that because obviously there are plenty of patients you put on your monitors, but in the world of my ICU, everybody's on a monitor.
Everybody. Yeah.
Everybody's on a monitor, so I'm gonna catch this AFib no matter what.
Yep.
So that would be hard to sell in the world of veterinary medicine because since you don't have everybody on monitors, I guess what's the advantage? So that's a tough one. But if I
Yeah.
it, my go-to answer is because its safety profile is better.
That's wonderful. Yeah, it honestly is the same exact way for our patients as well. It's super safe, very little downside, basically, if any, and basically, these patients that we don't have monitors. I mean, we utilize other methods and things like that to assess for arrhythmias, like auscultation and whatnot, and listening for particular rhythms, like the shoes in a dryer rhythm and whatnot while we're listening to their hearts, and making sure that there's no arrhythmias that we're appreciating, basically. But that's experience based, and not everybody's experienced in this field, so that gets missed. And it's just something that I feel that veterinary hospitals really need to reconsider at this point in time. So that's awesome. Thank you. Um, so do you have any pointers for how new grad DVMs can take their education or mentorships into their own hands?
Well, I mean, I tell every single person that goes into medicine that your education is your responsibility, not anybody else's. No one's going to teach you this stuff passively. You
Hmm.
have to go seek it out. So, for me in the world of medicine, it's always being curious, always being inquisitive, always asking the question why. when something is anything you come across that's new, is to ask the question why. Why is that happening? Why is this not happening? Why are we doing this? Why are we not doing that? You know, to lean on those that you consider to be mentors, whoever that may be. And that might be not be anybody in the beginning of your career. That could be just literally professors, could be classmates. It doesn't matter because you once again you can learn something from anybody. So, it's a combination of self-reflection, self-motivation, and I guess making the professional connections.
Mhm.
I mean, my connection started with classmates, and then it evolved into coworkers, and
Mhm.
then it evolved into people I met online, as well
Right.
as people I met at conferences. You know, you
Working.
you gotta have a yeah, so you gotta have a thirst for knowledge because
Yeah.
I
You've
mean,
committed yourself to become a lifelong learner in medicine.
I mean, what I learned 20 years ago is almost not even applicable now. So it's you really, I mean, that's why we have what are called that's why you're required to do continuing education
Mhm.
because by literally the definition of the word, you have to continue your education. No
Yep.
one's going to do it for you. Now, you're going to have to do a little bit of work in the beginning of your career to figure out where that is.
Mhm.
Like for instance, um, as a nurse practitioner, you you have the option of being a member of all of these professional organizations. There's the list is endless, and you're going to have to spend money to become a member. And you may or may not get some benefits of a journal. You may not get some benefits of like discounted prices on things, but you really want to be part of a professional organization that actually helps you grow as a professional, whatever that looks like for you. Because in the beginning of my career, that was networking, that was maintaining my CMEs, my CU. Now, what that looks like is where can I get the most CMEs for the least amount of effort? You
Right.
know, I'm a part of what's called the American Association of Critical Care Nurses. I've been a member of that organization since I was a baby nurse, which was 20 years ago. And I acquired a certification through their organization called my CCRN. I've had that certification now for going on 18 years.
There
But
you
the only
go.
reason why I maintain it, the only reason why I maintain my membership is that they have a wonderful CME package. Like as a member, I have access to just unlimited amount of CMEs, and they're small, but they're easy to acquire, they're easy to obtain. So like every month there's a journal that comes out that has somewhere between the range of 2 to 5 CEUs. I get that for free. I
Mhm.
can do that every month. I can do that every 2 or 3 months, and then you can go to the website, and there's additional CMEs that you can go and get. If you wanna go to the conference that they have every year, you can get upwards of, like, 30 CMEs at their conference, so and, both online and physical conferences afford you both education and networking. And I guess at the end of the day, the networking is both to grow professionally, but personally, because I don't know about you, but I really hate feeling alone when it comes to this profession. I really
Absolutely.
hate I really hate that like what I think is happening only to me, the minute that the minute I discover that what has happened to me is happening to everybody else, it makes it just
Mhm.
a little bit less burdensome. It makes it
Right.
a little less painful. And
Right.
then you find common ground, and then as you make these connections,
Mhm.
then you help each other out.
Yep.
Hey,
Shift the perspective.
yeah, when you share something with them, they share something with you, and then what's really cool about all that process is that in the beginning you make all these connections, and then as your profession progresses over 5, 6, 10 years, whatever, maybe your job changes. Maybe you move to another state, or you have other interests somewhere else and you want to advance your career in some way, or you want to go back to school and you don't know what to do about that. And then all of a sudden, your connection from 7 years ago says, "Hey, I know someone down there. I could hook you up. I can give you their email. I'll give you their phone number." And then all of a sudden, it makes it real easy to do the next thing. So
Yeah.
you want to investing in your future, as cliche as that sounds, you really do have to invest in your future, because the people that I met 20 years ago, there's a handful of them that I still communicate with in some way, shape, or form. And it goes both ways, because I'll have people from 10, 15 years ago who will contact me and say, "Hey, I have a friend, I have a classmate, I have a coworker who has this person who's looking for this. You have anything for me?" "Absolutely. Here,
Mhm.
let me give you that." You know?
Right.
So I don't know how else to be. I don't know how you can survive in this profession any other way,
Right.
because any other way is probably one of the most lonely and painful way to exist. So
Absolutely.
I hope I answered your question.
No, absolutely. Like, it's the same in veterinary medicine. You've got to go ahead and, give yourself as many opportunities as possible to meet as many people as possible and learn as much as possible. And, make sure that you're identifying and being honest with yourself, your deficits, and working on those things, and making sure that you're developing yourself in the right ways, the most bang for your buck, and, getting the job done at the end of the day.
I mean,
Yes.
as a new grad, in that very
Mhm.
first job that you get, it's all about establishing your practice. It's all about establishing yourself as a clinician, learning the job that you trained for,
Mhm.
and becoming proficient in that job.
Mhm.
Once you've done that, however many months or years that takes, then you have to take the next step. And the easiest step to make is what's right in front of you in your job, is to learn from that person who has more experience than you. Ask them questions. Learn
Absolutely.
from the new person that just showed up. Ask them questions.
Mhm.
Like when I was a new grad as an NP, um, managing a ventilator was intimidating for me, because
Mhm.
as a bedside nurse, I had become pretty pretty versed in ventilators. But when I became the person who had to manage the ventilator, that became very intimidating and scary.
Yeah.
So I promised myself that anytime a respiratory therapist or a physician stood in front of a ventilator, I velcroed myself to them. And I would just sit and watch for the longest time. And after they do whatever they were doing, back then it was like magic what they were doing. I'd be like, "Can I ask why you did that? Why'd you why'd you choose that?
Right.
Because I'm not understanding that." And 99% of the time, everybody loves that.
Mhm.
Now I'm the person who's in front of the ventilator doing this, and I'll have a nurse, I'll have a student, I'll have a coworker come up and be like, "Why'd you do that?" You know? And that's where you start.
Absolutely.
Everything else is, once you pass that threshold, I think that's when it gets easier, is that you gotta be confident. You gotta get past the imposter syndrome, because we all have it. I'm sorry, it's ingrained in
Self-worth
us.
is not inherent.
Yeah, you have to literally step over the line and just, you gotta put yourself out there. You gotta take the leap. You really gotta
Yep.
take the leap. It's just, you gotta stay hungry, because school
Absolutely.
school is not where education stops. School is where it starts.
It's just the beginning.
Yeah. Okay, now I'm done.
All right. So, for our last topic, how to see 3 to 5 steps ahead in any critical care scenario. Any tips there?
Time. Quite honestly, time.
Hmm.
It's I in previous profession of mine, I was a coach. I've also have a pretty strong fitness background.
Mhm.
I've coached. I've trained both as a coach, and then personally, I like to do a lot of things when it comes to fitness. So the correlation here is that a muscle doesn't get stronger without putting in the reps. And it quite literally can be applicable to everything you do in your profession. Things get easier the more reps you put in.
Absolutely. The more
Art,
experiences, the more patience.
it's just
Hmm.
the art of anticipation is not a magical thing. It's not something that all of a sudden you just cross this imaginary line, you step through this imaginary threshold, and all of a sudden you know how to do it. It's just there. It is after hours upon hours upon thousands of hours of working at your craft and putting in the reps. There's a reason why, physicians go through residency. There's a reason why there is an orientation to whatever job you do. Is that you just have to put, and I also have a military background. Is that you have to have time and grade. You just have to have time and grade. You have to think of it this way: is that when the very first day you're a student versus the day you graduate, you're a very different human being,
Oh yeah.
every way, shape, or form. Because there's the world you knew prior to being in veterinary medicine, and now there's the world that you live in. Two very different worlds. And the only way those two worlds became different is the amount of reps you put in, the amount of hours you put in. You know, uh, the schooling for a nurse to a nurse practitioner is about 3 years. The schooling for a nurse can anywhere be where from 2 to 4 years. And I always talk about life before nursing and life after nursing. You were two very different people.
Right.
You look at the world differently. Everything from the simplest to most complex thing, you look at the world differently. And it's the same thing in your profession. The
Mhm.
first day you show up in that very first job, you're not going to know a thing. You're really not going to know a thing. 6 months, 12 months, 2 years later, you're going to be a very different person. And the more reps
100%.
you put in, the art of anticipation gets easier because it isn't about being able to predict things. It's about familiarity with signal. It's about pattern recognition. It's that you've seen that heart rate and that blood pressure with that particular illness 17 times before, you know exactly what's going to happen next.
Yep.
Or you know of three scenarios right now that are going to happen. So you're going to anticipate that move. And that's how it works, is that you see it once, twice, you see it over 5, 10, 15 times. That's why someone who, like me, has 20 years of experience, I do it effortlessly because I've seen it a few times. I've done this a few times. Whereas someone who, if this is the first time they've ever even seen AFib RVR, they're like, what do I do? That's how it works, is that things only get less scary the more you're exposed to it.
Right.
There's no shortcut to that. There is no shortcut. Believe me, I've tried. There's
You've
no
got to
shortcut.
give yourself time and grace.
You do. And part of the imposter syndrome is that we like to beat ourselves up for not being as smart and as skillful as the person next to us. Even if even when that person next to us has 10 years of experience on us, we feel like I should be doing what they're doing. I should
Right.
be as smart
Inferior.
as them. And it's unjust and unfair that we do that to ourselves, is that we think that they expect us to do what they do when that's not the case at all. So it's just we all want to be perfect. We all want to be the best. We all want to perform at the highest possible level. We also have to give ourselves some grace. We also have to just
Mhm.
be okay with not being okay. Be okay with making mistakes because that's how you learn.
Yep. And we have all made mistakes in this field. Anyone that's been here long enough has made a mistake. And, honestly, when it comes to bouncing back from making a medical mistake, I think that, giving yourself grace during that time and, just making sure that, you are fully being transparent with yourself and the others, around you and affected about the situation is, 100% what counts at all times. It's a very difficult thing to bounce back from. And, it negatively affects all of us, but it's super important to just make sure that you take the lesson and you commit it to heart and to memory, because you don't want to ever do that again.
I mean, it doesn't matter how long you've been doing this. Everybody makes mistakes.
Yeah,
Um, I think
we're human.
everybody gets caught up in the fear.
Hmm.
I think fear is your greatest ally. It's what keeps you in check. It's what
Hmm.
saves you from mistakes. It's what saves your patients. Nobody nobody does anything on purpose. It's just safety measures, et cetera, et cetera. But I've made mistakes. I still make mistakes.
Yeah,
So it's everyone thinks that you're going to get through this profession by not making any mistakes, and that's a flat out lie. Anyone that
absolutely.
I don't know where that came from because I felt that way too when I started.
Yeah,
Felt that like if I make a mistake, I'm fired. If I make a
right.
mistake, I'm not worthy. And
Yeah.
it's the opposite.
No,
Now,
most
you
veterinary
do have
hospitals
to
have
learn from
policies regarding medical errors, and it's basically a process of how many mistakes have been made, and judging the situation by that degree versus a mistake and you're fired. So
yeah, and it's if you make a mistake once, it's because you were unaware, uninformed, or misjudgment. But if you
yeah,
make the same mistake twice, then that's on purpose because you didn't
yeah,
learn, because you didn't
yep,
adjust your sales, because you didn't make the changes that you needed to make.
yep. That's why I was saying, you've got to be very transparent with yourself and, commit this to memory and make sure that, you're not repeating, this mistake in the future, because it will happen.
Yes, it will, unfortunately.
Mhm. Yeah. Well, I want to thank you so much for all of your insight, pearls of wisdom, and whatnot. This has been absolutely wonderful talking to you through this. I cannot thank you enough for joining us tonight. This has been absolutely amazing. Thank you so much, Sean.
You're welcome. I had a good time. I learned a lot too.
Awesome. We do have a question in the Q&A section that I'll read out real quick. Let's see. Any tips for communicating with that DVM who struggles to reconcile the changes in a critical patient with how they think it should be going and or the diagnosis? Nothing more frustrating than checking SpO2 on 3 different machines because the result doesn't fit with their diagnosis. Rapid or unexpected changes in patient status seem to be hard for many to cope with from a case management standpoint.
Oh yeah, I mean it really has everything to do with being open. I mean I deal with that as well in the human medicine world with physicians that are not willing to be wrong, I guess.
Hmm.
Um, in my world, I have other checks and balances that if I have to, I can supersede the physician. I mean, basically, I'm calling the boss's boss in order
Right.
for us to do what's best for the patient. Um, I guess if I had to give a suggestion, it would be to explore why the DVM is questioning the numbers as opposed
So,
to accepting the change in the patient's condition.
right. Particularly in veterinary medicine, we have much less accurate machines and monitors for SpO2 than what is in human medicine. Yours are much more accurate than ours.
Gotcha.
So basically, it's due to the location, the fact that, the veins and capillaries are much smaller and whatnot in our patients, but it's much more difficult to get a accurate oxygen saturation level, basically utilizing these monitors in veterinary medicine.
I think then it would come down to collating data. So in human medicine, if somebody is truly hypoxic, there's other signs, there's other symptoms, there's other there's other things that are affected. So
Right.
I guess I would use that to support my decisions on if the SpO2 is saying this, and then you're checking three different machines, and the DVM is still not agreeing with what the SpO2 readout is, then my step would be on each one of those machines and each one of those cases, I would be gathering the other vital signs to support whatever it is that I think is going on. So in
Absolutely.
the world of human medicine, if I think that someone is as hypoxic as the number says it is, I'm finding other ways to support that idea. If they're that hypoxic, then they would be much more hypotensive. They would be much more tachycardic. They would
Mhm.
be much more unstable. They would be much sicker, or they would look much more what we like to say toxic. They would look much more toxic because
Mhm.
I think we all can agree that if your pulse ox readout says 68, someone who has a pulse oximetry of 68 is going to look a certain way.
Yeah.
And
Full cyanotic.
I think that's an element of experience is that I guess that's where I would go with that is that if you truly believe that the machine is accurate, what other evidence do you have to support that? Or if you truly believe the machine is inaccurate, what other evidence do you have that supports it? So if the machine says 68 on all three machines, but yet you have a normal heart rate, you have a good blood pressure, and you're able to evaluate someone's perfusion in some way, whatever way that is, if you can evaluate and you feel comfortable with someone's perfusion, then I would ignore the pulse ox, quite honestly. Or if you are able to, if you have the capabilities of doing a blood draw, there are other ways to support or defend or refute whatever that machine's telling you,
Right.
because nobody's care should be directed by a single piece of data.
Right.
And I think
100%.
that's the answer is that um it's kind of like when I tell human patients family members that they look at a monitor and they focus on one number. That number is high, that number is low, that waveform is wrong, it doesn't look good. It's not about a single piece of data, it's the whole picture. You got to look at the whole picture.
Yep.
You
The
know,
constellation.
if someone's that hypoxic, what about their urine output? What about other things that support or refute that idea? So, and I guess
Right.
that's where I would go with that, is be an expert at assessment skill.
Absolutely. So in veterinary medicine, the ways to, basically support, the SpO2 on all of these monitors would be to go ahead and assault the heart rate and, make sure that there's no arrhythmias or anything like that. Go ahead and, feel the femoral pulses in that animal and, see if there's any pulse deficits, things like that. What is the consistency of the pulse? Is it, bounding? Is it, thready? Where are we at with this? Take a lactate and go ahead and run blood gases, things like that. There are tons of things that we can do to go ahead and to support or refute, something like that.
I mean, and quite honestly, if it was me, if I know that many of these machines, the pulse ox is not reliable, I would just eliminate it from the equation altogether, because then
Absolutely.
that would eliminate the argument, that would eliminate the conversation, and you just focus on all the things that are reliable. And I think
Muddies
that's
the
why,
waters for people.
yeah, like, for instance, when I have someone whose perfusion is so bad that my pulse oximetry is wrong no matter what I do,
Mhm.
just we ignore it. We're done.
Right.
We're done focusing on a number that is we
Oh, it's
know
rolled
is
out.
wrong. And that's literally what we do in patients who are like in refractory shock. If
Mhm.
they're in refractory shock, they're clamped down, my pulse ox is not going to work because it's
Yeah.
based on perfusion. It's based on the refraction of red blood cells that are oxygenated versus not oxygenated. So if someone is horribly not perfusing, or if their hemoglobin level is horribly low, my pulse ox is going to be wrong in every way. And
Yeah.
if the
That
waveform is
SPR is going to be up
horrible,
there.
I've literally had it happen the other day on the
Mhm.
last couple of shifts I had, is that we are looking at the pulse ox and we're like, wow, that's really low. That doesn't make any sense.
Right.
You check other values, other data, and then you check a blood gas and realize, oh, that pulse ox is wrong in every way. We're done checking that. You know
Yeah,
what? Just remove it completely. We're done checking that.
exactly. Why complicate the situation even more?
And I guess that would be the ultimate, is that between you and the DVM, you have that conversation. Listen, we
Mhm.
know that this machine's pulse ox is not the most reliable. And if it's okay with you, I just want to eliminate it altogether so that we stop going down that rabbit hole, because it's not helping any of us. If we feel that there's something else going on, we can dive into that other areas. You can auscultate, you can check perfusion, listen for arrhythmias, pulse, all that other stuff.
Mhm.
Eliminate pulse ox altogether. And that's, quite honestly, if it was me, that's what I'd be doing.
Yep, totally agree. Well, thank you so much for your time tonight, Sean. This has been absolutely wonderful, and I'm gonna let everybody go now. And I really can't thank you enough. This was just such a great talk. Thanks so much for coming.
You're very welcome. Thank you for having me.
Of course. All right. Talk soon. Take care. Okay. Have a good night, everyone.